Hello, and welcome to today's webcast, Shingles, Vaccinations, and Psoriasis. My name is Bev Bromfield, and I'll be your moderator for today's presentation. Before we start, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane, and the dial-in information will be displayed. You'll have the opportunity to submit questions to today's presenter by typing into the questions pane on the control panel. You can send your questions in at any time during the presentation. We'll collect these and address as many as possible during Dr. Feldman's Q&A session. Since some of you may be new to the Foundation, here's a little background about who we are, our mission, and what we do. In 2014, the National Psoriasis Foundation developed a strategic plan which drives everything we do as an organization. To achieve our mission, the following goals were identified: accelerate discovery to cure psoriatic disease, improve health outcomes, achieve goals to help reach our mission, whether it's being involved with an event or becoming a volunteer. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis and a better understanding of what it means to live with psoriatic disease. If you have psoriatic disease, you can help accelerate efforts towards a cure and a greater understanding of the disease by participating in the NPF Corona National Psoriasis Patient Registry, which is the largest independent observational registry of psoriasis patients in the U.S. This registry represents a network of dermatology clinics that collect and study patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatments, better understand conditions that are related to psoriasis, and to explore the history of the disease. You can share your experience with researchers about what it means to live with psoriasis and psoriatic arthritis by participating in Citizen Scientist. Answer questions and view your data with over 4,000 participants. Data is used to help researchers gain a better understanding of the disease. To learn more and participate, visit the websites listed on the screen. We continue to improve health outcomes through our Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. The Foundation's Patient Navigation Center is available to help you find physicians, treatment information, navigate insurance issues, access support through our one-to-one program, and more. Contact us at 1-800-723-9166 or visit psoriasis.org/navigation center. To achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in local Team NPF events near you. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar where you'll learn more about the prevalence of shingles and the risk amongst those who have inflammatory diseases, guidelines for use of the live vaccine versus the non-live recombinant vaccine when taking immunosuppressive therapies, resources to help gain a better understanding of psoriatic disease and treatment options. Now I'd like to introduce you to our speaker, Dr. Stephen Feldman. Dr. Feldman is a professor of dermatology, pathology, and public health sciences at Wake Forest University School of Medicine, as well as the director of the Psoriasis Treatment Center at the Department of Dermatology at Wake Forest Baptist Medical Center in Winston-Salem, North Carolina. Dr. Feldman is board certified in dermatology and dermatopathology. His chief clinical interest is psoriasis, where his passion is to help guide how individuals with psoriasis are treated. Dr. Feldman is a member of the American Academy of Dermatology and a President's Council member of the National Psoriasis Foundation. He is also a member of the Foundation's Medical Board. He is a frequent speaker for patient education activities, physicians, industry professionals, and managed care executives. It is my honor to welcome Dr. Feldman, who will present the latest information about the shingles vaccine and other vaccinations in relation to psoriatic disease. Please welcome Dr. Feldman.
Thanks so much. It's a great pleasure to have this opportunity to talk to y'all. Here's my disclosure slide. If we mention products for the treatment of psoriasis, I probably have a potential conflict of interest since my research and teaching and has been supported by many companies, and I consult for many companies. Before I go any further, though, let me thank Joe Marola and Emily Baumrin. They did a lot of work for the National Psoriasis Foundation to come out with Psoriasis Foundation guidelines on vaccinations, particularly for shingles. They prepared an early version of this presentation that I used as a starting point. And they're wonderful. I start off by making sure everybody understands what shingle is. Shingles is a recurrence of chickenpox. Chickenpox, when you get it, I think you inhale it, it goes throughout your body, you break out in rash all over. Shingles is not all over. It's a recurrence of chickenpox, but it only occurs in one area or a limited area of the body when it flares up. You can see here how it's on one side of the abdomen. It's not necessarily just on the abdomen. It could occur on one side of the face, on one hand, on one thigh, but it tends to occur on one side for reasons we'll discuss in a moment. And you'll see it consists of small blisters that are all grouped together. And that's a characteristic appearance of herpes zoster or shingles. This recurrence of chickenpox causes a blistery rash to occur in basically a band along the body. This slide shows pictures of chickenpox itself. So here's somebody who broke out in chickenpox all over. These are small little blisters. You could see on a close-up look, they're blisters at different stages of evolution, and some are getting better, some are just starting, and they're all over the place. When chickenpox occurs, it lasts for a while, then the immune system recognizes it and gets rid of the virus. But the chickenpox virus doesn't leave us entirely. It likes to hide in the nerves of the spine. And so it hides in the spinous nerves. And when the immune system is lowered for some reason, then the body can't keep the chickenpox virus under control. And the virus will start dividing, it'll break out, and it will go down one nerve. And if it goes down this nerve, then it's going to make a band in this area of the skin. If it started here and it broke out, well, then it would be on the side here. If it was on this nerve, on this side of the body, then it would go this way. We have one nerve for one side of the body, one nerve for the other, and since chickenpox breaks out in one nerve, you get the band on one side of the body, not the other. One of the things I love about shingles is what it teaches us about the anatomy of the nerves of the body. So the nerves come from the spine, and the neck ones go down and around. So they go around the side, then they move to the front. Ones here on the upper back come down to the shoulder, and then they move down into the arm and hand. Ones on the trunk will give that characteristic band-like appearance on the trunk. Ones down here towards the bottom of the spine might get an area of buttock, and then it would go down the leg beyond that. Here's another way to look at the nerves of the body. Let me go back to one slide. I just want to show you the face. Well, we saw the nerves of the neck, so those are here. There's one nerve that does this side of the jaw and chin, another nerve for this side. One nerve that does this cheek, another nerve for this side of the face. And then one nerve that does scalp, comes down, does the eyelid, and then down to the tip of the nose. And a second nerve would do the opposite side. And so somebody could break out in shingles on this portion of the head and the tip of the nose. And one of the signs that we worry about is involvement of the tip of the nose. If we see involvement of shingles on the tip of the nose, then we send the patient to the ophthalmologist to make sure it's not affecting their eye. I love this picture of the human body. This sort of shows, the distribution of the nerves of the body. And then there's the nerves in the front, and then you move backwards, the neck nerves, and then these would go down and get down to here and do the thumb, and then the next one, some fingers. Then you get to the trunk ones, then you get to the ones that go down the front of the leg, then the ones that go down the back of the leg, and then all the way to the very bottom. So here is somebody who has shingles. You see the grouped blisters in various stages of evolution. It doesn't cross this side of the body. It doesn't cross onto the left side of the body. It stays on the right side, because there's one nerve from the spine going to the right and another nerve from the spine going to the left, and the shingles virus reactivated in this nerve, getting this part of the body. So hopefully I've given you a sense of the nervous distribution of shingles. I just want to show you on one more slide. If shingles breaks out in this nerve, and this nerve does this part of the body, and that nerve takes care of the skin along this area, this is where those blisters are going to appear. Here are a couple typical examples of shingles starting, doesn't cross over to the right side, so on the left side, it involves this side of the body runs down the back of the arm a little ways. That's the distribution of one nerve of one of the spinal nerves, the one that was affected in this patient. Here's another example. This person may have been somebody who had it. I don't know if it's the same person as we just saw, where it came around from the back to the front, but notice it doesn't cross to the left side. You have these groups of blisters, almost like little collection of grapes, very typical of herpetic infections, herpes virus infections. And chickenpox is a form of herpes virus. It's called the varicella virus. It's not a herpes simplex virus, but they're somewhat related. I mentioned to you that there's a nerve that does the cheek and the upper lip, and so this person has involvement of that nerve. So the herpes zoster or shingles creates a shingle. That's why they call it shingles, because it's like one shingle of a roof. It's one band on one side of the body, and it lasts for a while. It can be painful. You may feel the pain even before the rash starts. When the skin hurts and you don't see any rash, it could be early shingles. The shingles, the blisters will last a while, maybe a week or two, and they go away. They crust over. They're contagious while they're blisters and active. While they're in this phase, they're infectious. But they're not nearly as infectious as chickenpox, because in chickenpox, it's throughout the body, it's in the lungs, it makes you cough, and you cough it on other people, and it spreads airborne. If it's only in the skin, then airborne spread is minimal if it occurs at all, and it would only be spread by contact, which if it's on a covered area, I'm not sure I've ever seen, shingles spread to another person. And if you did catch it from another person, you wouldn't catch shingles, you would catch chickenpox. So you can't give shingles to another person. You would only be able to give chickenpox because it would be a new exposure for them. It wouldn't be a reactivation in a nerve if it was a contagious episode. So these rashes, these examples, are a little painful, could be a lot painful, but it lasts for a week or two, and then it goes away, and the rash clears up. It might leave some mark, some scar, but it gets better typically. Unfortunately, in some people, damage to the nerve causes persistent pain, and the term for this is post-herpetic neuralgia. So the shingles doesn't last long, but the pain can. Now, if you're young, say under the age of 55, it's very uncommon to have this post-herpetic neuralgia problem. The pain usually goes away when the rash does in young people. But if you're like over the age of 75, it's pretty common for the pain of shingles to last a longer time. And it would be nice if preventing shingles would prevent the post-shingles pain. So by preventing shingles altogether, we prevent the post-shingles pain. Once you have shingles, I'm not sure how much the treatments for the shingles prevents the pain. There are some herpes virus treatments. There's some pills like acyclovir or valacyclovir that can be given in large doses, and they may reduce the period of the shingles a short while. And it's possible that they reduce the pain of shingles, persistent pain, somewhat. Some people wonder if anti-inflammatories like prednisone might reduce that pain. But the pain is an issue for older patients who get shingles. Once you're over the age of 70, 75, then it becomes somewhat common to have post-herpetic pain. And herpes zoster seems to be increasing in frequency, possibly because more people have suppressed immune system. And if you suppress the immune system and your body isn't able to keep the zoster under control, the virus can break out in that nerve and cause the shingles. So the best way to prevent the post-herpetic neuralgia is never to have herpes zoster or shingles in the first place. The herpes zoster is more common in people with lower immune systems. So in the general population, 2 out of 1,000 patients in a year will have shingles. So that's somewhere between 1 in 250, 1 in 500 people in any given year will have shingles. But it's more common in the rheumatoid arthritis population. What's this? It's about 2 to 5 times more common in people with rheumatoid arthritis. In people with lupus, with an immune system that's not working right, the rates can be even higher. But you could see even the highest rate for the lupus, 90 per 1,000 patient years. That's maybe 1 in 10 people in a year would develop shingles. That's the highest estimate. The vast majority of these estimates are much lower than that. How about psoriasis? Study looked at the general population and found a rate of 8.5 per 1,000 patient years, so that's 1 in 100 patients per year. And in psoriasis patients, psoriatic arthritis patients, it looks like it's about 50% higher. Now, if you say the chance of getting shingles is 50% higher if you've got psoriasis. That sounds bad. It sounds like half the people get shingles. No, but that's not what it means. It's 50% higher rate, and the rate goes from a little less than 1 in 100 to a little more than 1 in 100 per year. So the rate is still very low. It's increased in psoriasis, but it's not increased a lot. How much of that increase is due to the psoriasis itself versus the treatments that psoriasis patients take is not clear. Some of the medications that are used for psoriasis or psoriatic arthritis can increase the risk of having shingles. In particular, tofacitinib. There's some good evidence that that medicine is associated with a higher risk. It's a drug approved for psoriatic arthritis. Don't think it's approved for psoriasis yet. And there is an increased risk of having shingles if you're on that drug. If you're on a cortisone medicines by mouth, corticosteroids, and some psoriatic arthritis patients are, there's increased risk there. If you're on a higher dose, the risk is greater than for a lower dose. The biologics like the TNF inhibitors, Stelara, the IL-17 inhibitors, the IL-23, the new drugs like Tremfya, Lumian, Skyrizi, these drugs are associated with no or minimal increased risk of developing shingles. Now, again, if you hear, well, if you're on tofacitinib, you're at increased risk of having shingles, that sounds bad. But so what you really want to know is how big is the increased risk? Well, here it says there's a 2 to 3-fold increased risk of herpes zoster, shingles, in the psoriasis studies. But again, if it's 1 in 100 per year and it goes 2 in 100 per year, that means that 98 out of 100 still don't get shingles. If it goes to 3 in 100, that means 97 out of 100 still don't get shingles in any given year. So yes, there's an increased risk, and it's a big relative increased risk, 2 to 3-fold, but the absolute increased risk is still pretty small. I mentioned that internal cortisone medicines at doses of more than 10 milligrams a day is an increased risk. Again, it's maybe 2 to 3-fold, so still 97 out of 100 still are not getting shingles in any given year. So how do you prevent viruses? The main way we do it is with vaccines. There are a whole variety of vaccines that people can use. There's live vaccines like the measles, mumps, rubella that children should get. I guess a bunch of parents haven't been vaccinating their kids, and now we're seeing measles outbreaks. These live viruses, these live vaccines are given when people are young, typically. Yellow fever is a live vaccine. I have patients who are going on mission trips to Central America who will get yellow fever vaccination. The chickenpox virus vaccination that children get is a live vaccine. Typically, if you're immunosuppressed, you want to avoid live vaccines because they're live and you could have an unusual infection from one. People with healthy immune systems, the live vaccines are well tolerated typically. There's dead vaccines, inactivated or killed virus, and people who are immunosuppressed can take these because these inactivated vaccines don't cause a problem. And then there's subunit or recombinant vaccines that are just a part of a virus, like the new shingles shot. And these have no potential for causing infection. They just boost your immunity to the virus when you vaccinate people. Let's talk first about the live vaccines and their use, although they're not of much importance anymore, particularly the live vaccine for zoster, because there's a new dead vaccine that's even better. We have the live zoster vaccine and the recombinant zoster vaccine that we'll discuss. If you're going to give patients a live vaccination, you want them to have a normal immune system so they make sure they can fight that live virus off. And so typically you'll stop their immunosuppression before giving them the vaccination. Then you'll wait for their immune response, give it a month or a few months before restarting the immunosuppressive therapy. Some medications like methotrexate, if you're on a very low dose, are so mild on the immune system that you can even take a live vaccine. So you don't have to, avoid the zoster vaccine just because you're on a little low dose of methotrexate for psoriasis or psoriatic arthritis. Low strengths of cortisone, if it's topical steroid, if it's some very low dose, say below 20 milligrams of prednisone a day, again, your immune system's still working well enough to fight off viruses, and you could take a live vaccine. Up until recently, the only vaccine we had for shingles, to prevent shingles, was a live zoster vaccine, a live vaccine against the chickenpox virus. It was an attenuated vaccine, and so the risk was low, and you would have roughly a 2/3 reduction in the rates of shingles in 60 to 70-year-olds, a 40% reduction in patients greater than 70, and a 2/3 reduction in the rate of the persistent pain syndrome, post-herpetic neuralgia. And so a lot of older folks would want to get their zoster vaccine when they reached either 50 or 60 years old. And again, you would give it before taking immunosuppressive therapy, stay off that immunosuppressive therapy for a few months after getting the vaccination. But fortunately, a piece of the shingles virus was used to develop a new vaccine. So this vaccine is safer than taking the live Zostervac. And apparently it's considerably more effective. So the rate of reduction of herpes zoster was over 95% in 50 to 60-year-olds, 60 to 70 years, and even in the older patients greater than 70 years old, a 90% reduction in the risk of herpes zoster. You saw it was a 40% reduction in the risk with the old live vaccine. And in addition, there's a 90% reduction in the risk of post-herpetic neuralgia. These are phenomenally terrific rates of reduction in risk with this very safe medication because it's just a piece of the virus. It cannot cause infection. But I want to temper my enthusiasm with a more global look at what this risk reduction means. Because remember, only 1 in 100 people, only a couple out of 100 are going to get shingles to begin with. It's not like everybody gets the disease and now 96 out of the 100, 97 out of the 100 don't get the disease. You start off with, over the course of 3 to 4 years without vaccination, about 3% of people develop shingles. So that's 1 in 100 per year. There's a 90% reduction in the rate. So that goes from 3% down to 0.3%. So yeah, you've reduced it by 90%, but your chance of getting shingles was only 3% over a 3-year period anyway. So only about 1 in 30 people was getting it. Now it's down to 1 in every 300. So yes, it's a marked reduction, but even if you didn't get this vaccination, you were unlikely to get shingles. If you did get shingles, only 1 in 10 people get the persistent pain. So only 0.3% out of that 3.5% would get the post-herpetic neuralgia. Again, over 3 to 4 years, that's 1 in 300 people. And now you've reduced it by, 80%, it looks like, down to less than 1 in 1,000, which is great. Maybe it's on the order of 1 in 2,000, but that's maybe an 80%, maybe 90% improvement. But still, even without vaccination, 299 out of 300 weren't going to get post-herpetic neuralgia. So I don't know that it's critical that people take this vaccination. My gerontologist recommended I get it. I think it's hard to get now because it's such a popular vaccine. They have trouble making it fast enough. So I haven't gotten it yet, but I'd certainly consider it. It reduces the risk by 90%, but again, the risk is so low to begin with that 90% reduction is only a small difference in risk for the average person. The side effect of vaccination is primarily pain. You can have whenever you get a vaccination, you could get some bruising or pain at the injection site, maybe some headache or tiredness for a while, from the vaccination. But there's no risk that the virus is going to spread in your body because this is only a tiny piece of the virus that cannot cause infection. The cost, I hardly ever know what the cost of something is because everybody's insurance is different. But without insurance, I think the cost is about $300. The vaccination is often covered by insurance, especially if you're older or you can make the case that you need it because, say, you're immunosuppressed and older. So here's the standard vaccination schedule. The recommendation for the live vaccine was to wait till you were 60 years old and get 1 dose. The new vaccine, the recombinant, the one that's only a piece of the virus that cannot cause infection, it's recommended that once you reach the age of 50 that you get it and get 2 doses of it. Now, if you're at higher risk, say because of psoriasis or other immune disease or the immunosuppressive effects of a steroid or tofacitinib, it's probably more important to get the vaccine. They haven't lowered the age range for it in those patients, but you might think about getting it earlier or make sure you get it if you were in that situation. This next chart shows the vaccination schedule for people in different situations. Again, for the Shingrix, the new shingles vaccination, it's still 2 doses at the age of greater than 50, even if you have any of these things that might affect your immune system, like diabetes, end-stage renal disease. And there doesn't seem to be any recommendation that you have the Shingrix just because you have an immunosuppressive disease, but some people might think about doing it. The live vaccine is contraindicated in immunocompromised patients. The dead vaccine isn't recommended by the CDC, but some doctors might tell you it wouldn't hurt to get it. So the National Psoriasis Foundation experts got together, put their heads together, and they said basically that getting that new recombinant shingles vaccine psoriasis patients should have it before going on systemic therapy. But if they're already on a systemic therapy that will affect the immune system, it's okay to go ahead and take that recombinant vaccine because it's not a live vaccine. It won't cause problems. And if you're already on in immunosuppressive medicine, yeah, maybe it wouldn't hurt to get the vaccine. Certainly, if you're over the age of 50, you're supposed to get it anyway, and so it wouldn't hurt to get it. And if you're less than 50, but you're on tofacitinib, the Psoriasis Foundation experts said, since you're at higher risk, you should go ahead and get this vaccine. But again, it's a 2 to 3-fold increased risk, but that's only a small risk because it's only 1 in 100 per year to begin with. So it goes to 2 in 100, 3 in 100. If you think reducing that 2 or 3 in 100 risk is important to you, then I think it's reasonable to go ahead and get that recombinant vaccination. Doctors and patients can think about whether they want to do the shingles vaccination in other situations on a case-by-case basis. That's all I wanted to cover in this portion of the program, and I think we can open it up for question and answers.
Thank you, Dr. Feldman, for your presentation and providing a very informative webinar about the latest information regarding the shingles vaccine and celiac disease. We appreciate your time and expertise today. It's now time for the Q&A portion of this webcast. If you have any additional questions based on what you've just heard, please submit them now through the questions panel on your attendee interface. We'll attempt to answer as many questions as possible in the remaining time. Our first question is, what are the risks of getting the vaccine?
Yeah, so the dead vaccine, the Shingrix, you may feel some pain when they inject it, and there could be some pain, say, if you have it injected in your shoulder, maybe for a day or a couple days. The detailed list might include redness, itching, swelling, warmth, bruising, or pain at the injection site, but I would expect all those to be very minor. Headache, muscle pain, tiredness, or fever can occur. And again, it'd probably be temporary. A little Tylenol probably would put it at bay. I don't think there's any serious risk. I guess some people can have allergic reactions, to any kind of immunization. If you get it, if you have any trouble breathing or swelling around the lips, throat, tongue, that sort of thing, then you want to see a doctor right away. But that would be true for basically any medicine that a person took.
Okay, this question is along the same lines. I just had my second Shingrix or booster shot Tuesday, and the injection site is a little sensitive and slightly warm to the touch. Is that normal?
I think the first shot probably caused immunization and got your immune system all excited. And then the second shot, your immune system already knows to recognize it, and now it's probably creating even more inflammation there. And so the increased pain the second time could be just a sign that the vaccination's working beautifully. And I think a little Tylenol or Motrin, if you're allowed to take Motrin, would probably relieve that if you even need it. And I expect it's going to only last for a day or two before it gets better.
Okay, now the follow-up question. Because this is not a live virus vaccine, is it now okay to give myself my normally scheduled biologic shot for psoriasis?
Yes, totally. In theory, if you're on an immunosuppressive medicine, then the shot might not work as well as it would if you weren't on that immunosuppressive medicine. But most of the biologics we use for psoriasis offer so little immunosuppression that it probably doesn't matter. If you're on an IL-23 inhibitor or an IL-17 inhibitor, I don't think there'd be any effect at all. Even the TNF inhibitors probably are not going to affect your body's ability to mount an immune response. If your psoriasis was on the mild side and you wanted to wait a week or two, and hold the dose to give the immunization a chance to work, you could, or you probably could just go ahead and take your medicine right on schedule and be fine. So if you're on the immunosuppressive medicine and you get this dead vaccine, there is no risk that the vaccine is going to cause infection. It's just a question of how well the vaccine will protect you in the future. If you're on an immunosuppressive therapy that's very immunosuppressive, then yeah, the vaccination might not work all that well. But I don't think any of the typical psoriasis medicines, biologics, are so immunosuppressive that they would really limit the effectiveness of the vaccine. I think the vaccine probably will still work just fine.
Okay, if my doctor just put me on methotrexate, how can I get the shingles vaccine?
You can ask your dermatologist or primary care doctor to prescribe the vaccine to you and administer it. Would be another way. You take the prescription in the pharmacy, fill it, and get the injection. If you're on a low dose of methotrexate, you can go ahead and take the vaccination, no problem. Again, methotrexate will not increase the risk of the virus, the vaccination causing a problem. Because it's a dead vaccine, it is not going to infect you.
And do you take shingles shots every year?
No, one time. It's 2 doses, and then you're done for life.
And is there a higher prevalence between psoriatic arthritis and HVS2?
Not that I know of. I think that's probably HSV2, which is a herpes simplex virus, cold sores, genital herpes infections. I don't know that there's any higher prevalence in psoriatic arthritis patients. If you're on psoriatic arthritis medications that lower the immune system, I guess it's possible that there could be more herpes simplex virus, but it would be a small rate of increase. It probably wouldn't be a noticeable thing in any given person.
And how often does a reoccurrence of shingles hit psoriasis patients?
I want to make sure I understand this question. There's 2 ways of thinking about recurrence of shingles. So shingles itself is a form of recurrence of chickenpox, and it happens in psoriasis patients maybe 1 in every 100 years. So if you have 100 people, it'll happen in 1 of them in 1 year, roughly, give or take. If the question is, will the shingles recur? That's rare, because once you've had shingles is like an immunization against the virus. And so your immune system gets ramped up against it. And it's very unusual to have a second outbreak of shingles. So if you had shingles in 1992, that was probably like getting another immunization to shingles in 1992. Now, that was a long time ago. And I suspect most doctors think that if you're over the age of 50 or 60, especially if you're on anything that's even remotely immunosuppressive, it would probably be a good idea to go ahead and take the Shingrix vaccine just to, reduce that risk of shingles even further.
So how long does Shingrix protect someone who has psoriasis? What is its effectiveness?
Those studies lasted 3 or 4 years, and it was like a 90% reduction. And so if you only have about a 1 in 100 chance to begin with, and you reduce it by 90%, now you're down to 1 in 1,000 chance per year of getting the disease. The studies went out to 4 years. I don't know, how protective it is 10 or 20 years later, but I suspect it's very protective is my guess. Because if it's like 90% at 4 years or 97% at 4 years, it's probably still 90% effective at 10 years.
Now, in this circumstance, someone has already had the live virus shingles vaccine. Should they take the attenuated shingles vaccine?
That's a great question. We saw that the live vaccine reduced risk by, roughly 40 to 67%. That's an improvement, but it's not the 90% risk reduction you get with this recombinant Shingrix vaccine. So I think most doctors would say, yeah, go ahead and get the Shingrix, vaccine now and, reduce your risk of the shingles considerably more. And if you're at higher risk because of psoriasis and because you're on a low prednisone for your psoriatic arthritis, or you're on a TNF inhibitor, or if you're on tofacitinib, then yeah, it makes really good sense to go ahead and get that Shingrix vaccine.
And should you go ahead and get the Shingrix vaccine if you've already had shingles?
I think so. I believe that having shingles once protects you greatly from having shingles again. But the Shingrix vaccination is so safe that it might be something to discuss with the doctor. I don't know that there's any one right answer to this. I think if you were on, say, cyclosporin, a fairly high dose of cyclosporin, and your immune system was really shot because of it, then sure, go ahead and get the Shingrix. Makes good sense. If you just have psoriasis or psoriatic arthritis and you're on Motrin or topical therapies, then you probably don't need it. But again, it's so safe and there may be some benefit there. It's hard to say in that situation.
Okay, and our last question. Someone has a scheduled injection for izukizumab. Is that a problem in relation to taking the shingles vaccination?
It's certainly not a problem as far as the dead shingles vaccine, the recombinant vaccine, the new one, Shingrix. It's not going to cause the Shingrix vaccination to be any more risky. It's very safe. It can't cause infection, so there's no risk. I guess the question might be, would the ixekizumab reduce the effectiveness of the Shingrix? And I personally believe that interleukin-17 has nothing to do with your response to viruses. And so I think there's some reasonable data that shows that other IL-17 inhibitors have no effect on your body's ability to mount an immune response. So I would go ahead and stay on the ixekizumab just according to the regular schedule and just go ahead and get the vaccination, not change that ixekizumab dosing at all. Go ahead and take it is what I would think would be appropriate.
Thank you again, Dr. Feldman, for your time and for sharing the latest updates on vaccines and psoriatic disease. We really appreciate your insight.
My pleasure. Thank you all for participating.
In addition to today's webinar, upcoming webinars about psoriatic disease are listed here. Podcasts are also available through Apple Podcasts, Google Play, Spotify, iHeartRadio, or a feed service of your choice. You can also access current and past podcasts at the website listed here. The podcast released Tuesday addresses factors that may indicate a need to switch treatments. Contact the Patient Navigation Center to receive a free flare tracker, or if you still have questions, would like additional information about treatment options, finding a physician, or having issues with accessing treatments, contact our Patient Navigation Center by phone, email, or text. Once you leave today's webinar, you'll receive a survey to provide feedback about the presentation. Tell us what you think. We value and appreciate your comments. Finally, you can access our webcast archive at psoriasis.org/webcasts. This concludes our presentation today. Thank you for attending.